Today we have so many stalwarts with us who have headed our department for a long time, and it will be opportunities for postgraduates to know who steered the department to this level. We have Dr. K.N. Agarwal, Dr. M.M.A. Faridi, who are our former head of the departments, and we seek their blessings and continued support. Now I hand over the mic to Dr. Anurag Agarwal to continue the proceedings.
Thank you, ma'am. Respected Dr. K.N. Agarwal, sir, Dr. Sir, Dr. Anita Khalil, madam, Dr. Faridi, sir. Sir, आप box में चले गए? अच्छा. And other faculty members and young students. I can see Dr. Kiran Agarwal and of course Dr. Anju Agarwal, madam, the host of the program today. First of all, I thank the institute for organizing this monthly meeting program in this institute, and traditionally every year in the month of September we have this program in this hospital on the 3rd of Thursday. Last week we had PCNI, a lot of you must have attended it, and so we shifted it to the 4th Thursday, but because Thursday is a holiday, we shifted it to Wednesday. And not taking much time, I would invite the chairpersons for the program today, Dr. Faridi sir. Dr. Faridi sir will introduce our speaker and our legend for today, Dr. K.N. Agarwal sir. So we started off this series, Legends of Delhi, this year, and we have been requesting our extremely senior faculty members or legends of Delhi who have brought a perceptible change in the practice of pediatrics in Delhi, across India and across the world to our forum, and we request them to share their experience as to how pediatrics evolved over last 50 years or so, last half a century, because they have been practicing pediatrics from 1960s, 70s and till today. So how pediatrics, which was a small section in our medicine exam, has evolved to a full-fledged branch and now is going into sub and super specialities. So in this series, Dr. K.N. Agarwal sir is here and Dr. Faridi will introduce him. Along with Dr. Faridi sir, we have two more chairpersons who are practicing pediatricians from East Delhi. Dr. Ashish Makkad, please join, and Dr. Rakesh Kumar Bhatia. Sir, please join the stage. Handing over the mic to Dr. Faridi sir.
Good afternoon, friends. It's indeed a very, I won't have words for addressing a very stalwart. The people, today we are calling him legend. I think he's more than that. And I've known him since 1976. And I'm really very privileged that today who examined me and these years were awarded by him, along with Dr. P.K. Mishra. They were my examiners at Aligarh. And then the fate has such a quirk that ultimately I requested him to come to Delhi to make this department, establish this department. I have one more opportunity. One of my examiners in MD, Dr. O.P. Ghai, who joined this institute in 1988 as head of the department professor till 1991. So I was again very privileged to work with him, under him, although he examined me, and I just narrate you one story that on one short case, legal tradition is that one short case given to all the PGs and one short case individually to, and of course the long cases are different. And that short case used to decide who will ultimately pass. And that case was brought from District Hospital, Malkhan Singh Hospital. And 45 minutes I was examined on that. And when my head of department, Dr. Mr. Ansari, she said कि भाई और भी करना है और लोगों का भी होना है. I was the first roll number. और अभी वाइवा होगा, ये होगा, वो होगा, X-ray and all that. So he said, no, let him go. And you can imagine that if you do not appear for viva and table vivas and all that, naturally what will be condition of yours? I thought everything has gone away. But then fortunately, I was the person who got passed and rest two were not that lucky. I mean, we were three. And then I had an opportunity that he was here and I worked under him. So I'm a very lucky person that way that two stalwarts, Dr. O.P. Ghai, managed this medical college as head of the department and I worked under him. And then Sir came here and established this medical college, the department. And today what you see in the department is all because of him. I'm extremely thankful to him, sir, that he will always be sending me best wishes and always sending me Ashirwad. I am very grateful to him. Now, having said that, I will just say a small incident also when he was very often coming as examiner to Aligarh. And I being the junior most lecturer there, I was responsible for managing the examiners. And the popularity of Dr. K. Agarwal was, you can imagine that in 1976, 77, 78, there were not many trains to Banaras from Delhi. And Deluxe was one train, sir, in which there won't be ticket available from Aligarh. And then Bajaj said, don't worry, just take me to the station and things will be managed. And believe me, the TT of that compartment or AC compartment will be standing at the gate and looking for. This was his stature. And extremely popular when he was in BHU. Many of his students are here. Prerna is here. Many people are here and I'm seeing and in fact the principal of this medical college is also his student Dr. Piyush Gupta. I'm not seeing him here. Now this is my personal but coming to the formal introduction, actually he doesn't need any introduction as far as Dr. K. Agarwal is concerned. We all have grown up studying his growth charts and in the examination we are given answers to about what should be the weight of the child and what should be the, and then very late, maybe 20 years, the WHO grade chart came, but still whatever his research based for our own locality and community, his growth chart still stands even the date of the today. Dr. Saab passed his MBBS from KGMU and then DCH and MD from Delhi University, Maulana Azad. But then in between he was to Uppsala University in Sweden, and there he did PhD, which is designated there as MD. So he did PhD, and few of you will be knowing that although he shifted to growth and development and adolescent, but actually hematology was his subject. And when he was a faculty in Maulana Azad, in fact, he established the department of hematology at that moment of time. And then they went on to BHU, and there is the dean of IMS. And then he was director of Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. And that was a time when he made several changes. And in fact, there was nothing like of pediatrics there at that time. But actually, he was able to have at least department of neonatology established over there. And one of his student, in fact, selected one of the students there in hematology. She is now VC of KGMU. Only a few days back, she joined Sonia Nityanand. She's also actually a hematologist. So, and then he came over to here in 1993, and then he headed the department. And then after that, after the superannuation, the University of Delhi has a tradition to having the stalwarts as professor in the department. So he continued in 2002, and after that he handed over the baton to me, but he actually remained the head of the department, and we had a number of problems in the department because of the location where we are situated. It always became the third choice for the postgraduate students and so also the faculty. Hardly any faculty like to stay here. They all want to go because it's distances and all that. But then he was able to manage the very small faculty. He was able to manage the whole show. Today the department has grown up. Now there are, I think, 17, 18 faculty members, 45 PGs. And then when I left, before leaving this place, I was able to increase the number of seniors then to 31. I don't know how many of them are actually in place because of reservation issues and all that. But yes, the department now boasts to have a very big MCH block. That's again the brainchild of Dr. Saab. This actually they were having to have a maternity wing, but then Dr. Saab insisted, that we should have, and then Dr. D.K. Srivastav ultimately agreed. He was also from KGMU and was able to have the MCH block, and we are very comfortable now and having a very big department headed by Dr. Anju. So with these words, I once again thank the IAP for giving me this opportunity. This is a dream for me. I tried to write down something about him, but I couldn't, although I read some of the things from my personal interactions and also from net. But I thought, no, that's not appropriate. Let it be more informal kind of a thing. A shishya introducing a guru says something which is very difficult to actually express the views. So I will again thank the IAP and thank my legend who agreed to come over here and be introduced by me, who is actually has no standing before you, sir. But please shower your Ashirwad always on me and my family. We always remain indebted to you, and thank you very much. And I'm sorry I've taken 5 minutes more, and I hand over to my co-chairperson to say a few words.
Yeah. very pleased to. I will introduce myself. I am Dr. Ashish Makkad, a simple practicing pediatrician. So nothing academics. Totally we are out of academics, and this gives us an opportunity to interact with youngsters as well as our senior teachers, whose books we have been reading. Agarwal charts, which is like in our brains. I mean, way back in PG days. Nowadays we don't do anything. That's very frankly, patient comes, we just, write the medicine and go. But actually we love the academics, and it's a pleasure and it's an honor to be here and see such great personalities of our field. And at the same time, you see youngsters also, your blood also becomes, double to learn a lot of things, and a lot of things to learn from youngsters as well. So with these words, I'll give Dr. Bhatia to say something.
Myself, Dr. R.K. Bhatia, I am practicing in East Delhi itself, and I thank IAP Delhi for giving me this opportunity to seek blessings from such stalwarts of our field. Agarwal sir, Mittal sir, thank you.
I know it's a little unusual that I'm taking it. I have known Dr. K.N. Agarwal since 1969. I was first year postgraduate student. You were, I think, lecturer at MAMC. We had a picnic together. I was at the Ames, and he was at MAMC. That was the only time the two departments got together in the history till now. And the first thing which I learned from him was that you can be a very good academician and at the same time being jovial. You don't have to be all the time look very glum, serious, and say you are an academician. You can be a good academician while being a good social person. That was the first thing. And ever since then, I have considered him almost like my elder brother. More than that, more than elder brother, although I've never had an occasion to work with him, but because I was at the faculty at Maulana Azad, after he left Maulana Azad, and he was an ex-student of Maulana Azad, he always calls me jokingly as his HOD. But I have always considered him like my Dronacharya. You understand, the Eklavya was never with Dronacharya. But anybody will tell him where you learned the archery, he will say, I learned it from Dronacharya. And that is what I will say, sir. And wishing you all the best in life. And Mrs. Agarwal, thank you very much.
So, sir, may I request now Dr. K. Agarwal to kindly deliver your before he takes over there, I just like to share with you that when he was here, probably in 2003, 2004, Lady Irwin College, we had a talk by Dr. K. Nagwal on iron and during fetal life and effect on the neurodevelopment later on. So there was a master class research by him, and so I'm sure that he probably will be also be talking a few things about that, and that will be very interesting. So Dr. Kirwal sir.
Respected teachers for tomorrow, I am very happy to have your blessings. I will be happy to have more years of life with your blessings. इसको आगे बढ़ाओ. I have a letter from my teacher from Uppsala. This letter was written on 29/10/1965. And the letter said, you are trained to serve India. You are trained for every technique, and you must serve your country to make us proud. We Swedes are waiting to see you rise. This is the thesis that I wrote in Sweden, for which I was awarded MD. I had one examiner from Germany, another from Boston. Next. I returned to Maulana Azad Medical College. Dr. Shanti Ghosh kept full records of what I am doing and how things are moving. She was powerful enough, and she got a post of pediatric hematology lecturer created before I landed. I joined Maulana Azad Medical College as pool officer, built a pediatric hematology lab, and served the Delhi with hematology. All medical colleges, Safdarjung, my wife comes from Safdarjung, Lady Harding Medical College, all were bringing their slides and research problems, and I was helping. I tried to get a job, but it didn't work. That lecturer post, every time I went for an interview, they said, you don't have a qualification. But in those days, even DCH was enough to become a reader and professor. Anyway, I moved to Varanasi. वापस लाओ. कहाँ गए? इधर जाएगा. I moved to Varanasi as reader, shifted the lab and the ICMR project which I had done. I forgot to tell you. In 1969, I won the first STHR award for Maulana Azad Medical College. So, with the lab and the ICMR project, I moved to Banaras University. They gave me all facilities to build an exemplary department of pediatrics with high teaching standards, clinical care and research. The teachers for today, university supported. They blindly signed all papers that I could do, and I gave them a department which even has a reputation of a good department. Worked on hematology, nutrition, growth and development. In 1985, ICMR awarded a special nutrition center with 3 faculty positions from the UGC, and that was what I left. Then I worked on the problem of iron transport, anemic mothers, and I demonstrated that an anemic mother will proportionately transfer the iron to the fetus. There is a placental barrier, but placenta has priority to track iron to itself. Anyway, this was the first time it happened. My own teacher, Walquist, had not demonstrated it. He thought it's parasite. Ramalingam Swami always in his paper said fetus is a parasite. But they were changed in thoughts because a series of papers that we produced from Banaras made a hallmark for placental iron transport. Next slide. Fetal liver stores iron. But if the baby is born before 36 weeks, the baby will have only half of the iron, not the full. So it is proportional. Therefore, preterm deliveries, early deliveries will have low iron. Breast milk has property to trap iron. There are ferritin receptors. Faridi has also worked on this problem subsequently. We created a rat model. In the rat model, we showed maternal latent iron deficiency. There is iron deficiency without anemia. Even this iron, this is small deficiency, lowers the iron in cerebral cortex, cerebellum, hypothalamus, midbrain and corpus system, but no change in medulla oblongata and pons. Fetal brain iron content did not change after maternal iron supplementation. Even if we gave supplementation by IV routes, oral routes, it didn't change. And this altered all the metals in the brain which were responsible for formation of neurotransmitters. The iron deficiency creates a situation of irreversible neurotransmitter change with specific to iron deficiency. And it cannot be reverted, it cannot be changed. So it's a permanent damage to neurotransmission. In undernutrition, the neurotransmitters get corrected partially or completely. The significant effects on neurotransmitter receptors during early stages of iron deficiency clearly indicates the deficit in both excitatory and inhibitory pathways of CNS. This is Ganges. In this very period when I was working on this feto-maternal iron transfer, Mrs. Agarwal did a commendable work of declaring Ganges polluted. This was a huge crime. It was debated in Parliament, and the then Prime Minister Rajiv Gandhi reached Varanasi to inaugurate Ganges Clinic. She was awarded Sheshadri Award by the ICMR. In this period, with lot of work that we had done in Banaras, we became famous. I am a pediatrician. I was a pediatrician. I reached Sanjay Gandhi. There was no one in UP to compare the biodata. So I, who is a pediatrician, had no department there, and then I started working in PGI. This was a research period. This was a research period for administration. And I did landmark work for pediatrics in the history of the institute. I reserved one DM seat in each subject for MD pediatrics. My own head of the department, Farmer, was wrong in saying that there was no seat in 1991. I started blood transfusion medicine. They said, what is this? This is not in MCI. I said, blood transfusion is one thing where maximum tragedies are happening. Wrong blood, HIV blood. Who will head the department? I am the person who will head the department, and I have appointed one associate professor and one assistant professor, and conducted the first MD examination under my chairmanship. Today PGI Lucknow stands on the international map. I am very happy the institute is running. Next slide. Dr. Gopalan, a great teacher. He had a great insight for the country. We worked with him. He prepared blueprint for goiter control in India. There is no goiter today. Earlier in our OPDs there were goiter only. The government accepted our recommendation, universal iodation of salt. Mrs. Agarwal's knowledge of polluted water worked here, and we found that the water pollution is one of the very important factors for this. We studied nutritional status and mental functions in rural children and discovered learning disabilities. Midday meal program improved attendance, IQ, and performance in maths. Government implemented this program on recommendations of UNICEF on our work. Then we moved to growth in affluent Indian children birth to 5 years. Before taking up this work, I went to London and studied with Dr. Tanner. I worked in his department as a student. I told him that I am a student and I am wanting to set up a lab for growth and development. So, we moved. Anemia and pregnancy inter-age differences. This we did with Dr. Gopal. Anemia prophylaxis was done in department UCMS by Dr. Hema, Dr. Som and Dr. Diksha Kapoor. Studied minimal protein requirements in Indian vegetarians from the United Nations University in 1980. Now let us move to malnutrition, the talk of the day. We did the anthropometry, and anthropometry we did 0 birth to 5 years in 5 states, and then did semi-longitudinal study, and then 5 to 18 years cross-sectionally in 9 states. The other partners in the study were Dr. S.P. Khatua from Calcutta, Udani from Bombay, and Bankappa from Bangalore. This study ultimately gave us who is healthy, who is stunted, who is wasted, and who is wasted and stunted. Our studies were different than the British studies or US studies. We studied sexual development to diagnose underweight, wasted, stunted, overweight, and obese, and offered growth curves. We related all this growth to the sexual development, but we were not satisfied. It takes years to become stunted. It takes many more years to diagnose stunted, wasted. So we moved to the biochemical testing. The leukocyte-free alpha-aminonitrogen was demonstrated by us, which was published as the first paper in the British Journal of Nutrition in 1973. Then we tried in erythrocytes, but erythrocytes have a lifespan of 100 days. Leukocyte had 9 to 19 days. It showed increase in glutamic acid. Edema of fluid did not show any change. Finally, I moved to salivary ferritin in PEM, which was sensitive in recognition of severity as well early stage of PEM. It was published in American Journal Clinical Nutrition 84. This is non-invasive. Also good to diagnose iron status. Iron increases in PM, iron deficiency, aplastic anemia. And today, saliva is used in detecting cancer antibodies also. Newborn development. This is important. This is important for clinical pediatrics. A newborn's brain doubles in size during the first year of life. It grows especially in cerebellum. Newborn at birth has all the neurons, all cells that an adult would have finally. It only needs synapses, the connections, between the cells that really make it work, move, think, communicate, and just do everything. 1 million synapses are made every minute. Child at 3 years has brain growth by 80%, and by 5 years up to 90% or full brain. Therefore, these early years of life are very important and are a responsibility of pediatricians. A neonatologist cannot say, I have resuscitated and my job is over. You are looking after a future individual who can be your minister also, who can be your prime minister also. Undernutrition. Let me say what is the undernutrition. Intrauterine growth retarded offspring showed hypotonia, hypoexcitability, incomplete morose and crossed extensor responses. Their EEG, shortening of leaf cycle, intrahemispheric asymmetry, abnormal discharges showed dismaturity of brain. It was published in Acta Pediatrica and Archive Diseases Childhood. Poor neurobehavioral development was assessed by Gassels 6 to 52 weeks. In the age group of 6 to 8 years when the school period starts, the undernourished children showed poor intelligence. They showed poor conceptual development and motor development. This was assessed by WISP testing. Even those with IQ over 90 showed learning disability, difficulties comprehending or processing information, spoken, written, arithmetic calculation, concept, and reasoning organization, and integration of ideas and thoughts. Next. What are soft neurological signs? Please learn this. This is very important. Clumsiness. A child is walking to you and he is clumsy. Stereognosis. Recognition of solid to touch. Right-left confusion. Confusion in response to double simultaneous stimuli. Soft neurological signs are normal in preschool child. After preschool age, these disappear. And individual performs normally. But if he does not perform normally, he is abnormal. He has a brain damage. Stunted children 6 to 8 years old showed persistence of soft neurological signs with EEG abnormalities of slow and short waves, particularly in frontal lobe and also in the parietal and temporal lobes. Motor deficits were more marked on the contralateral side of the EEG abnormality. Soft neurological signs observed in preschool years persisted, 12 to 17.5 years. So even in adolescent, these signs persisted. Here is a child in the nation who is unskilled, who cannot coordinate. He is not fit for any high technical industry. So you may do IIT. You may become a very highly technical person, but if you have soft neurological signs, you cannot perform. You cannot perform. Chronic undernutrition affects brain for finer coordination. Next slide. Higher mental functions in undernourished adolescents. Reaction time studies showed effect on perceptual abilities, information processing and analytical capabilities. It is important to note that early life undernourished children continue to have prolonged reaction time, even if they had attained normal nutrition in later years. This is an important point. Brain growth has happened in the first 5 years of life. It is complete. So earlier you treat, if a pediatrician or a neonatologist follows the child up to first year, close 365 days, 50% brain he has nurtured. But if he leaves the baby on 10th day or 12th day, hand over to the pediatrician, he fails. And the baby will miserably fail in the later life. Now we move to puberty in endemic undernutrition. Height gain is under hormonal control. Therefore, whether you are undernourished or you are nourished, you will gain the same amount of height in adolescence. But the weight is not. So a child will not gain weight if he is undernourished more than 38% of the affluent Indian children. We had the data of affluent children, we had the data of rural adolescent children, we compare. What this child does, who is undernourished, he breaks all his muscles. It is demonstrated by the serum enzyme activities that we find LDH, ALP, AST, ALT, CK, CKMB and CKMM. All are markedly increased, muscles are breaking down. Child has to survive. Boys had delayed maturation of genitals and girls had delayed breast development and menarche. Next slide. Messages. Message is clear. Please elicit the nutritional status of the child. See how much is the wasting, how much is the height reduction. Elicit soft neurological signs. Reaction time. Reaction time, you can ask the child, turn pages. Find page 108. He will take 15 minutes to find 108. So this is reaction time. You pinch him here, he will not respond. So this is all reaction time. Treat female adolescents, they are future mothers in this country. Extend mother-infant neonatologist interaction for minimum of 1 year for nutrition and stimulation. Treat malnutrition at all ages. To treat and to find an answer, I reached to Dr. Faridi's department. He was my head of the department. And I started thinking what to do. First thing we did was, we went to Britannia company and asked them to give us some support. And so they gave us the dahi, which they brought from NDRI Karnal, and they gave us ultra-treated dahi. So there is no bacteria here. And then we got Actimel from Danone, which is the best probiotics supposed to be, but Danone has a fault. It adds in every cup 10 grams of sugar, which is too high. So we tried it in our wards. Then we tried in rural field work. Dr. Bhasin from community medicine did this study, and we concluded that the Actimel and Indian dahi can significantly reduce the duration of diarrhea in children. Here is the final story of the whole study on. These studies are done by Dr. Pooja Diwan, so I hold no responsibility if there is anything wrong. Here is all the lymphocyte cells are increased after 6 weeks if the children were fed dahi. But if the children were fed WHO milk, in contrast, these cells reduced. And so the Indian dahi, the Asian dahi have the same culture which Actimel had, and therefore we accepted this as an immunonutrient food. Next slide. WHO dahi diet increased all lymphocytes. In addition, cytokines, interleukins 1, 6, 10 increased significantly more with dahi in diet as compared to milk. Normalize the CRP activity in PM. Normally in PM or protein energy malnutrition, the CRP activity is blunted. It reversed and normalized. In contrast, the WHO milk diet depressed the absolute lymphocyte count. Dahi is an ideal weaning food and our children are in the weaning age. Use dahi as a weaning food. Make dahi at home. Give them. Their immunity system will develop. Lastly, we didn't stop there. We moved and we got to analyze a lot of vegetable green leaves. This is a fodder, see. This showed that if we use barsi, dried leaves, and mix them in wheat flour or mix them in dal or rice, or even give, it has a bitter taste. Give, it will serve the purpose. It has high protein content of 23%. It has been tried in Jaipur, it has been tried in many other places for iron deficiency anemia, and now this is being used with jaggery to pregnant women in ICDS. So Barsim has done the job. I must thank the Mother Dairy for standing with us, giving us the support, and the Dawars who manufactured the Barsim leaf concentrate for us. And thank Pooja Diwan, he didn't interfere. आपने हमारे को आज से फिट कर दिया लेक्चरर की जॉब फिर से हमने अभी एडवर्टाइजमेंट देखा था एक
Sir, with your permission, I take the liberty to tell one thing about dahi. See, when the Britannia, that yogurt came here, and we put this protocol for ethical clearance, our college didn't give it. They said that, tell me whether this dahi is food or dahi is a medicine. Because it was packed in a yogurt pan. We said, sir, this is food. He said, if it's a food, then you take permission from FSSI, where this is safe to be given. And if it is a drug, then go to drug controller. So our ethical committee didn't give permission. Then after that, with discussion with Dr. Saab, he said, okay, we send it to ask Karnal Dairy that about the content of the Indian dahi, the lactobacillus of there. There was a lactobacillus KZI and 3-4 more. So he said, no, it has to be certified by some publication. So then we wrote to CDRI, Karnal, and they were very helpful to us. They sent 5 papers published from Pakistan and from India that the Indian dahi, containing the Pakistan dahi also, has the organism which are routinely used in India, and they permitted ultimately to do this study. So this, we have a lot of problems with conducting this study in the department, but finally we were able to do it. So sir, thank you very much, sir, that the lot of work actually did take place at the UCMS when Dr. was here. Most of his work, thesis research work, and almost all papers won the national awards also. So sir, thank you very much for this is what I didn't want to, in a formal kind of a introduction, you will also realize what the person is and whom we are actually honoring today. Thank you very much. Anurag.
टाइम से 5 मिनट पहले पहुंचना है और दूसरा यू कैन नेवर से आई हैव नो टाइम टू डू इट टाइम इज द ओनली थिंग दैट यू हैव सो माय वाइफ और माय चिल्ड्रन गेट अप एंड सी दैट आई एम सिटिंग एंड वर्किंग थैंक यू सर
Thank you, sir. It was mesmerizing to hear you speak. Your journey over last 40 years, 50 years, it's really interesting how much work you did, how you moved around, and how you enriched the literature on which a lot of guidelines and charts were made, and we understood how to manage malnutrition. Thank you so much, sir. And with this, we move on with our felicitation program. I request Dr. K. Nagar, sir, Dr. Mittal, sir, please come. Ma'am, Dr. Agarwal, ma'am, Dr. Anju Agarwal, madam, Madam Anita Khalil. I request Madam also, Madam Agarwal also to please join. पहले सर को दूल्हा बना लेते हैं, उसके बाद सर, मैडम के लिए भी सर, पहले सर का, हाँ, फिर मैडम को साथ में, पहले दूल्हा बना दें सर को, फिर मैडम को साथ में, हाँ तो, हाँ सर ये आपका बिल्कुल, हाँ, सर की थोड़ी सी, सर एक मिनट, सेराबंदी कर रहे थे सर की, मैडम साथ में आइए आप मैडम साथ में आइए सर, मैडम को और सर को, ये मैडम की चुन्नी से मैच करता हुआ, ड्रेस से मैच करता हुआ, अनीता मैम प्लीज आइए मैम, आइए, हाँ मैडम इधर देखिए,
दर्शन करें आगे छोड़। हाँ ठीक है, आप देखिए सामने देखिए दर्शन।
पीछे से ले लो, शालू पीछे से ले लो।
Faculty from museum का, faculty from museum, faculty from museum.
आओ पूजा, सुमेरा, शशांक,
Faculty from museum में check करा।
अनुराधा इधर आ जाओ।
सामने देखिए सामने।
फोटोग्राफर आ गया, जिसको अलाउ फ्रेम में आ जाए। आप बैठिए। बैठो। क्या? सर बैठ जाइए, आप बैठ के।
So, to thank the chairpersons, Dr. Faridi sir. Dr. Faridi sir. Sir, छोटा सा मोमेंट है हमारी तरफ से. Thank you, Dr. Anita Khalil ma'am, to हमारे chairpersons को honor कर दीजिए. To honor Dr. आशीष मक्कड़. मैम हाँ आप दीजिए, हम यंग बच्चे इंस्पायर होंगे. And to felicitate Dr. Bhatia, Rakesh Bhatia. Please. Thank you. So, I hope all the young blood sitting here is member of IAP, Central IAP. Are you all members? Let me see how many, raise your hands, how many of you are members? Okay, around 50%. 50% is are members. So remaining, आप तो मैम, चलो आप भी young लोग ने मान लिया, मैं भी young हूँ, मेरा भी. अच्छा ठीक है. So, कोई बात नहीं, associate है, young PGs हैं, full members बन जाएंगे. So the remaining of you, please become members of Central IAP. You can get the link from any of us. All the faculty members have the link. You can ask us and we will provide you the link. The membership registration is just 10,000 rupees and it is lifelong. And you are all going to be pediatricians in future also. Whatever subspecialty you join, your parent body shall always be Indian Academy of Pediatrics. So please become its member and you will be getting lots of links wherein you will get lectures, sessions, webinars, CMEs, workshops, everything is there. Most of it is free, some of it is paid minimally. So become members. For example, on 14th of October, we are holding early childhood development workshop at Maulana Azad Medical College for IIT Delhi members. On 15th, there is a module on good practices in West Delhi. I think it is in Radisson Blue Hotel. The venues to be confirmed. So every month, literally, we have a activity academic teaching program, and along with that, we have lots of extracurricular activities also. So please become members and keep in touch with pediatrics, because once you do your post-graduation, you leave the institute, you will be into practice, and then you will be a bit away from academics. So this is the platform which will provide you with academics. Having said that, I move on with the program. So for the first case presentation, I invite the chairpersons, Dr. Anju Agarwal, madam. She is the head of department here, ma'am. Introduction ki zarurat nahi hai. Dr. Lallan Bharti, who is head of department pediatrics, JPC Jagat Pravesh Chandra Hospital, Government of Delhi, and presently President IIP East Delhi, and Dr. Amit Parashar, who is the senior consultant pediatrician practicing in East Delhi. So I request madam to introduce the case and take the program forward from here.
Good afternoon, everyone. Welcome to UCMS. And we have the first case presentation, an infant who presented with hepatosplenomegaly. I'll request Dr. Rajesh Meena to introduce the case.
Good afternoon, everyone. And from Department of Pediatrics, University College of Medical Sciences, we are going to present a case on an infant with hepatosplenomegaly and anemia, a less common diagnosis. Though at the end of this presentation, you are going to realize that this diagnosis is not that less common, but what we have chosen this case to present here because we are going to just highlight or emphasize the points what we learned from this case, why we label it as a less common diagnosis. So Dr. Jivansha is the final year postgraduate. She is going to take you through the case, and then we can have the discussion regarding the questions or queries you have about the case.
Good afternoon, respected faculty members. I'll be presenting the case of an infant with hepatosplenomegaly and anemia, a journey to a less common diagnosis. Presenting a case of a 10-month-old boy, resident of Meerut district, who presented with complaints of fever for 2 months, progressive paleness of body for 2 months, and progressive abdominal distension for 1 month. The fever was insidious onset. It was a high-grade fever with spikes reaching up till 102 degree Fahrenheit. Child had persistent fever spikes, 3 to 4 spikes per day. No history of any chills, rigor, any cough, coryza, or any rash. This was associated with progressive paleness of body, with irritability and decreased activity. There was no history of any yellowish discoloration of eyes, any bleeding from any side, nodular swellings, bone pain, or petechial rash. The mother also complained of abdominal distension, which was insidious onset, gradually progressing, generalized, associated with significant weight loss over last 2 months. There was no associated pedal edema, any breathing difficulty, facial puffiness, or any alteration in bowel habits. Child was treated prior to presenting to GTB. Child had received 2 blood transfusions and had got some treatment for fever. The investigations which were done outside revealed an HB of 7.2 gram per deciliter with a total count of 3,500 and platelet of 43,000. The HPLC done outside was normal and peripheral smear was suggestive of microcytic hypochromic RBCs with reduced TLC and platelet. Child was born to a primigravida mother at 21 years of age with an uneventful antenatal period, no history of any previous abortions or stillbirth. Child was born as a full-term normal vaginal delivery as an average size baby, and there was no history suggestive of any perinatal asphyxia. Child had never been breastfed. Child was always fed with diluted cow milk, 1:2 dilution with bottle feeding, and complementary feeds was started at 7 months of age, which was predominantly milk-based. Child was born to a non-consanguineously married parents with no history of contact with tuberculosis, no history of any bleeding disorders or blood transfusion in the family. Child had been immunized till 9 months of age and was developmentally normal. Child belonged to upper lower class by modified Kupuswamy scale. Coming to the examination of this child, general appearance, child was conscious and irritable to touch. Vitals, heart rate of 126 per minute, regular, normal volume, respiratory rate of 44 per minute, abdominothoracic. Saturation was 97% under room air and BP was between 50th to 90th centile. The temperature of the child at the time of presentation was 101 degree Fahrenheit. Anthropometry was essentially within the normal limits. General physical examination, there was pallor present, no icterus, clubbing, cyanosis, lymphadenopathy or edema. There were no skin rashes, any bleeding spots or purpurae, no dysmorphic facies, no neurocutaneous markers. Coming to the abdominal system examination, on inspection it was uniformly distended with a central umbilicus, no scars, sinuses, dilated veins and genitalia was normal. On palpation, there was no tenderness, guarding, rigidity or rebound tenderness. Liver was palpable 8 cm below right costal margin, non-tender, firm, smooth surface with rounded margins. And spleen was palpable 7 cm along long axis. Liver span was 13 cm. Bowel sounds were normally heard. Other system examination, including the central nervous system examination, cardiovascular system and respiratory system were essentially within the normal limits. So the working diagnosis which we had kept for this child was fever with hepatosplenomegaly with pancytopenia based on the earlier investigations under evaluation. The differential diagnosis which we considered for this child was first probably an infective etiology like enteric fever which would have lasted for 2 months. Secondly, leukemia. Thirdly, we thought of abdominal malignancies, neuroblastoma with marrow infiltration because this is the common age at which these abdominal malignancies present. Fourthly, we thought of HLH, and fifth as storage disorder, very much lower down the list. So to further differentiate on these diagnoses, we went ahead and did investigations for this child. The peripheral smear revealed a hemoglobin of 8.5 with a total leukocyte count of 3,800 and platelet of 55,000. On the smear picture, there were normocytic normochromic RBCs, mild poikilocytes in the form of teardrop cells, but not many atypical lymphocytes were seen. The impression of this peripheral smear was pancytopenia with moderate anisocytosis and hypochromia. Other blood investigations which we did, LFT serum bill was 2.2 against the direct fraction of 0.8, alkaline phosphatase was 368, KFTs were within normal limit, other fever workup, Vidal, RMAT, PS4MP was negative, hepatitis B and C was non-reactive, tuberculosis workup included chest X-ray, MAN2 and GA which were negative. Ultrasound whole abdomen done revealed hepatosplenomegaly with normal ecotexture of liver with no masses or lymphadenopathy seen which ruled out our abdominal malignancies. Mother HIV was non-reactive and blood culture and echo were essentially normal. We went ahead and did a bone marrow aspiration for this child, which showed a cellular reactive marrow with very few atypical lymphoid cells, less than 5%, associated with hemophagocytosis. The one which is pointed with a black arrow on the right image is our hemophagocytosis, which we better saw on the biopsy image, which actually showed the erythroid cells showed normoblastic to megaloblastic maturation. The myeloid series show all stages of maturation. We also did CD markers for this child. CD3, which is a T cell marker, was negative. CD20, which is a B cell marker, was also negative. CD34, which is suggestive of malignancies arising from epithelioid cells, was negative. And CD68, which is a marker of macrophage, was positive. In the right image with the red arrow, you can see the cell which has engulfed cells inside it. This is actually the hemophagocyte. Investigation specific for HLH which we did revealed a hypofibrinogenemia and hyperferritinemia along with hypertriglyceridemia, which is 548 of triglycerides against a normal range of less than 256 milligram per deciliter. Since secondary HLH is much more common entity than primary HLH, we had worked up the child to rule out any secondary causes of HLH. The viral etiology, including the CMV, EBV, HHV6 and parvovirus B19 was done, which was negative. Also, the workup for rheumatological disorders, including ANA and RF factor was done, which was negative. Meanwhile, while the child was still undergoing investigation and had been with us for 2.5 weeks, the child's condition worsened. So, in the form of respiratory distress and progressive abdominal distension. So, we had done a CECT chest and the abdomen for the child, which revealed bilateral central lobular nodules in bilateral lung fields, ascites, periportal hepatitis, and gallbladder thickness. So, we had planned to start the child on the HLH protocol 2004 with the induction therapy. Induction therapy actually consisted of 3 drugs, dexamethasone, high dose which was gradually tapered, then etoposide and cyclosporin. Along with this, we had started the child on IV antibiotics, Septran prophylaxis, IV fluconazole and supportive treatment in the form of blood transfusion. So, October-November 2022, this child presents to us, gets diagnosed with HLH 2004. By December, child was started on initial therapy with a tapering dose of dexamethasone, etoposide and cyclosporin. In Jan, while the child was being continued on the therapy, there was not much of a response noticed. So, we had considered an opinion and whole genome sequencing was suggested. At 15th week of continuation therapy, child developed GTCS type seizure with hypertonia and upgoing planters. The imaging done at that time showed cerebritis with hydrocephalus, which raised the possibility of either a newly added CNS infection or CNS reactivation. By Feb 2023, the relatives had finally agreed for the whole genome sequencing, and we had got the mutation in March 2023, which I'll be subsequently showing. By April 2023, when the child was in 23rd week of chemotherapy, child had developed super-refractory status epilepticus, was intubated and succumbed to death. So this is the basically showing what the CNS parameters, CSF parameters were. At the time in February when the child got CNS reactivation, the CSF cells, there were no cells, the protein was elevated and the workup for opportunistic infections was also negative, including the Cryptococcus, Cryptosporidium and Acanthamoeba. So hematological parameters during the course of the stay. As if you clearly see one peak which is shown in the center of the graph and then there is a downward trend. This is the time when the child was being discharged from the hospital. He had responded to the treatment initially and then in 15th week of treatment, child again developed CNS reactivation and again all the parameters worsened, including the platelets, TLC count and hemoglobin. The pattern of hepatosplenomegaly, we see in the middle of the slide there is a dip which is like after the response to the treatment, and again there is a rise when reactivation had occurred. So when in the March we got whole genome sequencing result which had revealed the UNC13D mutation. This was a compound heterozygous type of mutation confirming that the child has not got any secondary HLH but a primary HLH. So final diagnosis which we had kept for this 10-month-old boy child was familial HLH type 3 with UNC 13D mutation with CNS reactivation. Coming to the discussion of our case. What is HLH? HLH is basically a complex disorder that involves proliferation of the cells of the mononuclear phagocytic system. It's a hyperinflammatory condition where all the organs get infiltrated, resulting in finally failure and death. This systemic inflammation is the result of inappropriate and dysregulated activation of two cells, NK cells and CD8 cytotoxic T cells along with macrophages. So this is the criteria by HLH 2004 protocol. The ones which are highlighted in yellow is the one which actually fitted in our child before we got the molecular diagnosis. So our child had fever, lymphadenopathy, bicytopenia, hypertriglyceridemia and bone marrow revealed hemophagocytosis. So there are essentially two types of HLH. One is familial HLH and secondary HLH. Familial HLH is based on the genes study. So familial HLH from 1 to type 5 along with some pigmentary disorders like Chidiac-Higashi syndrome and Griscelli syndrome. Secondary HLH, it could be secondary to infection, malignancies, rheumatological disorders or any metabolic disorders. Infections, viruses top the list, and it can be secondary to bacteria, leishmania or fungi. Malignancies, most commonly the T cell malignancies. Our case was a diagnosed case of familial HLH, which is actually defined as presence of a biallelic pathogenic variant in 4 genes, PRF1, STX11, STXBP2 and UNC13D, which our patient had. Usually they present as an acute illness with prolonged and high fever, cytopenias and hepatosplenomegaly. Rash and lymphadenopathy are less common. They may also exhibit liver dysfunction and neurological abnormalities. They are usually evident within the first month or first year of life and may develop in utero. But there have been case reports where children up till childhood or early adulthood have been reported with HLH. So this is the flow diagram from Nelson. It just says anybody who suspected HLH first go along with flow cytometric assays, and then if you get a mutation, if you get an abnormality in perforin or granule release assay from the NK cells, we can further classify into FHL type 2, 3, 4 or 5. And then if it's a male, we consider X-linked lymphoproliferative disorders first, and if it's albinism associated, we also consider Chidiac-Higashi syndrome, Griscelli syndrome and Hermansky-Pudlak syndrome. CNS involvement in HLH, how do these children actually present? They present with irritability, bulging fontanelle in infants, neck stiffness, any hypo or hypertonia, convulsions, cranial nerve palsies, ataxia, any weakness, blindness and coma may occur. The neuroimaging done in these children suggests presence of white matter changes, hemorrhage, nodular lesions, generalized atrophy or brain edema. CNS involvement is much more common in familial HLH type 3. The challenges which we face managing this case, the NK cell in CD25 determination is difficult. It's not available at all the centers in India. Whole genome sequencing in itself is a very costly test, and relatives were reluctant to bear the cost till very later stage of the disease. Multiple sessions of counseling and disease prognosis were required to explain the poor prognosis of the disease, and no living donor was present for the stem cell transplant. Coming to the literature review of our case, so this is the flow diagram which has been suggested by HLH 2004 protocol. What I want to highlight in this is whether it's a persistent, non-familial, non-genetically verified disease, or it's a reactivation, or it's a genetically verified disease. First of all, we start with the HLH protocol, which consists of induction therapy and continuation therapy till they can finally afford the stem cell transplant. So there was a study, a single center study which was done in Gangaram, which had looked HLH cases all over up till 9 years, and they had considered all the pediatric HLH cases presenting to them based on the clinical criteria as well as the diagnostic criteria. The primary HLH in this study was reported in 27 27 individuals, and secondary HLH was the commoner one in the Gangaram study. It was the viral etiology, pyogenic etiology, HLH secondary to the autoimmune diseases, and etiology not detected in 6 out of them. They had reported the poor outcome of HLH overall up till 38% mortality in HLH. Then we looked at a study which focused only on the familial HLH part. This is a multi-center study involving 20 centers all over India over the period of 10 years, and they had studied 101 HLH patients. These were all familial HLH patients. What I want to highlight in this study is familial HLH type 3 is basically the common age group of presentation is 51% of them had presented below 1 year of age. Secondly, the CNS symptoms among all the types of HLH is more common with familial HLH type 3, which is up till 45%. So this same study revealed the outcomes of therapy seen in this different familial HLH group. 16 patients of familial HLH type 3, even though they received the entire protocol, they expired, which is up till 50% mortality. And 7 patients were well, 7 out of 35, which is up till 20% patients were well who had received the timely hematopoietic stem cell transplant. Coming to the study from Japan, which had shown outcomes in children with hemophagocytic lymphocytosis treated using HLH 2004 protocol, they had classified 73 patients into 3 groups: EBV HLH, familial HLH, and HLH of unknown etiology. The induction rate after initial therapy was 58.9%, which had significantly improved after the stem cell transplant. But the 3-year overall survival rate of all patients was 73.9%, and it actually differed in all these 3 groups. So usual outcomes, what happens to the children who gets familial HLH type 3? Those who have the monoallelic mutations have severe clinical manifestations, and all of them expire despite being able to receive stem cell transplant, which is the ultimate cure of HLH. Those with compound heterozygous mutation, like our patient has, 50% chance of survival only on chemotherapeutic agents. And lastly, familial HLH type 3 has the second best prognosis after FHL2. So learnings, what all did we learn from the case? If untreated, there are very poor outcomes of this disease. A 3-year survival rate of 55% in children who receive treatment with the protocol, and post bone marrow transplant, these survival rates reach up till 62%. And if there are no response to the usual treatment protocol, we should consider familial HLH much more earlier at the stage, and genetic studies should be done very early. Though a rare entity, a possibility should always be considered in all those who had presented with a prolonged fever and hepatosplenomegaly. Thank you.
Well presented case, Dr. Jivansha. Any question from the audience regarding this case? Dr. Lennon? Question?
No. Very nicely presented, though it is a very complex issue. So in this index case, what difficulty did you find in counseling the parents and evaluating the parents?
Sir, the main reason of choosing this case is that the HLH we all encounter during our clinical practice. But the reason being that whenever we are interacting or finding a child who's of younger age group, and whenever we have worked the child for the secondary causes and all reports are turning out to be negative, then we must think about the familial HLH. Because nowadays there are more and more reports coming from India as well as from outside centers where we are getting these familial HLH diagnosis on the basis of the gene studies. Because now we have the availability of NGS and the whole exome sequencing, on the basis of which in majority of studies they are making the diagnosis. So here the main difficulty what we faced here is the getting the parents ready to accept that the child is having familial HLH. Because someone who's coming from a rural background, for them familial means something which is affecting their family or their family is already affected with that. Another thing, the father was a daily wage worker. So throughout the stay, it was the grandfather and the mother who were the main caretakers of the child in the hospital. Father never turned up. And the last reason is that getting the diagnosis delayed is the monetary reasons. Because these investigations are not available at our center or even other government setups.
Dr. Rajesh, what exactly is the hereditary pattern of this familial HLH? Are there difference between 1, 2, 3, 4, 5? And what happened to the rest of the family members of this patient?
This was the first born child. And finally we lost this child. So actually we have not evaluated the parents, so we can't say that whether parents are affected or not. But in majority of cases, whenever there is a one group which is primary and then another group is secondary. So primary, there are the groups which are associated with these specific gene mutations and then associated with other conditions like primary immunodeficiencies. So they are coming under the primary HLH, and the rest where we are getting the, especially the secondary where we are getting the infection, one infection. So recessive, sir. So recessive, sir. Autosomal recessive. So वो अलग अलग है सबको. So she has the table over there if you want.
Thank you, team UCMS, for a lucid presentation on HLH, which has come up over last 15 years. We have seen numerous cases of HLH. In fact, I also had a publication around 8 to 10 years ago.
So even there is a one study from Bombay group. They have taken data from 20 centers across the India over a decade. And they have taken almost 100 cases, and out of that, she has shown the same data. 1/3 were from the type 3 only.
Yeah. So I think we move on with the next presentation. But before that, I would like to felicitate today's speakers and chairpersons.
Alek.
So first of all, the young student who presented the case, Dr. Jivansha Dua. I hope I pronounced the name correctly. Yeah. I request Madam, Dr. Anju Agarwal, Madam, to present a memento to Dr. Jivansha. Of appreciation to Dr. Rajesh Meena. Dr. Rajesh Meena. Please, and we would like to felicitate the chairpersons. I request Madam Kiran, Madam Anita Khalil, Madam, to please come over and felicitate. आपको हम बैठने नहीं देंगे, ma'am. So, Dr. Lallan ka? Dr. Anju Agarwal ma'am ka. Ma'am, one for Dr. Lallan Bharti, Lallan ka, and Dr. Amit Parashar. मैम अमित रह गया. So with this, I invite the next team. Dr. Piyush Jain, Head of Department Pediatrics, Hindu Rao Hospital, kindly take the dais, and Dr. Shalu Gupta sir, Consultant Director Professor Pediatrics at Kalavati Saran Children's Hospital, sir. Kindly take the dais. Dr. Ram Prakash Soni, Senior Consultant Pediatrician. Please come on the dais. Introduce the, I request Dr. Piyush Jain to introduce the case.
Thanks, Dr. Anurag. President Dr. Mukesh is not here, Secretary Dr. Ajay, Dr. Lalan from East Delhi, and Dr. Anju is Head of Department and our very gracious host for the today. We from Hindura Hospital is today presenting, the PGs will be presenting the case. It's a case of delayed diagnosis. Actually, it's a baby which came to us at about 2.5 months of age. Something was missing. This was the dilemma we faced. We felt something was wrong. We investigated and found what we thought was not there. Many of you probably, Madam, many of you would have probably read the novels of Earl Stanley Gardner, who wrote about Perry Mason. Perry Mason was a lawyer and an investigator. सर आपने तो शायद पढ़ी होंगी उसके अंदर उसके केसेस हमेशा लिखे आते थे केस ऑफ समथिंग 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 एंड वॉट एवर यू थॉट वाज नेवर the murderer in those novels. It's not that in this case the patient was alive and is kicking and is well. For whatever, our case is a case of delayed diagnosis. And the moderator for today is Dr. Ravinder, who is our senior consultant in charge of NICU. I'll hand over the mic to Dr. Ravinder.
Good afternoon, everyone. And all the ma'am and all the students. So, and thank you, Rajesh. After a very complex case, let us come to a very simple case we are daily seeing in our OPD practice. But you will be surprised and shocked. We are missing all these neonates. Thousands and thousands of neonates and kids, they are being affected by this disease. And still, I mean, neither at our medical fraternity level, nor at a state or central government level, they are doing enough to treat and to diagnose this case. So I know it's very simple but very important, because we just want to give a message. Probably now time has come for that. Please start this. What to start? My DNB, Dr. Kapil is here. He will be briefing about the case, and literature will be reviewed by Dr. Ankita. Both of them are my third year DNB resident. Over to Dr. Kapil.
Good afternoon, everyone. I am Dr. Kapil Rajat. I am presenting a case of delayed diagnosis under the guidance of Dr. Ravind Kumar sir. A Arab 2.5-month-old male baby, resident of Adarsh Nagar, Delhi, second child by order, born out of non-consanguineous marriage, belongs to lower middle class family, presented in routine OPD for vaccination. Mother was apprehensive that her baby is having decreased activity as compared to her first baby. History: he was a full-term baby, birth weight was 3 kg, born to 25-year-old mother, delivered via LSCS in some private nursing home. Uneventful antenatal period, cried immediately after birth, developed jaundice on day 6 of life. However, phototherapy was not required. At present, there was no history of fever, cough, cold, loose motion, vomiting, crying during micturition, feed intolerance, and abdominal distension. Past history: no history of hospitalization in past. Family history: maternal grandmother, known case of diabetes mellitus and on insulin. No history of sudden death, stillbirth. No history of hypothyroidism in family. History of tuberculosis in mother 7 years ago. Development history: gross motor, fine motor, speech language, all the developmental milestones were normal, except social smile was absent at the age of 2.5 months of age. Immunization: received birth dose and 1.5 month vaccination was completed. Dietary history: baby is on exclusive breastfeeding since birth, on demand feeding, no prelactals or top feed was given. General physical examination: baby was awake and vitals, all the vitals were normal. Heart rate was 130, respiratory 36, CRT was less than 3 seconds, pulse was normal, SpO2 98% in room air, temperature was 37 degrees Celsius. Head to toe examination: head size was normal, that is 40 centimeter, lying in 50th centile. Anterior fontanelle was widely open, that is 3 by 2.5 centimeter. Posterior fontanelle was open, that was 1 by 1 centimeter. Pallor was absent, skin normal, no any dysmorphic feature. Oral cavity and tongue was normal, neck no palpable mass, genitalia were normal. Anthropometry: weight 5.9 kg, lying on 50th centile. Height was 61 centimeter, that is lying between 50th to 75th centile. Head circumference was 40 centimeter, lying on 50th centile. All the systemic examination were normal and within normal limit. The differential diagnosis was sepsis, perinatal asphyxia, rickets, and congenital hypothyroidism. All the relevant investigation was normal except thyroid profile. CBC was normal, LFT, KFT, serum calcium phosphate, alkaline phosphatase, VBG, and USG cranium was normal. In thyroid profile, very high TSH, that was 464 milliunit per liter, and the free T4 was low, that was 0.4 nanogram per deciliter. On the thyroid scan, technetium 99 scan shows no uptake of radioisotope. So the suspicion, suspicion of thyroid agenesis or apparent athyrosis. And USG neck was done, shows bilateral lobe of thyroid gland normal. X-ray of both knee showed absent epiphysis. And the case summary: RF 2.5 month male baby presented with mother in routine OPD, and mother was apprehensive that her baby is having decreased activity. On examination, positive finding was open posterior fontanelle and with altered thyroid profile. The free T4 was 0.4 nanogram per deciliter. TSH was 464 milli international unit per liter. Scan in technetium scan, there was no uptake of isotope. And USG eutopic thyroid. X-ray knee, absent epiphysis. And on nuclear scan, there was no uptake. USG eutopic. So there is a possibility of thyroid receptor resistance or sodium iodide symporter defect or thyroid receptor antibody, thyroid receptor blocking antibody. So in my case, in mother, there was no history of any autoimmune thyroid disease. So less chance for thyroid receptor blocking antibody and more chance of thyroid receptor resistant or sodium iodide symporter defect. So the diagnosis was congenital hypothyroidism with possible etiology is TSH receptor defect or NIS mutation. Treatment was started with thyroxine 75 microgram per day, that was 3 microgram per kg per day. On follow-up, after 2 weeks, free T4 was 1.93, and after 4 weeks, free T4 was 1.6. Follow-up at 1 year of age, gross motor sitting without support, fine motor immature pincer grasp, speech and language can say voice level only, social recognize strangers. So the DQ was delayed, DQ was 66%, and free T4 and TSH within normal limit, that is 1.6 is free T4 and TSH was 3.5. Follow-up at 2 years of age, gross motor walks with support, fine motor immediate scribbling, speech and language can say 1 to 2 words with meaning, social milestone, that copies parent in task, and the DQ was 63%, and free T4 was 1.9 and TSH was 3.8. So the learning point is screen in all newborns, repeat in preterm, SGA, sick baby or on drugs. Nuclear scan and ultrasound in all. High dose levothyroxine if severe hypothyroidism. Keep T4 in high normal range, and regular follow-up is essential. Thank you.
Good afternoon, everyone. I'm Dr. Ankita Ritura, DNP resident from Hindurao Hospital. Today I'll be discussing on congenital hypothyroidism. So congenital hypothyroidism, as we all know, is the most common preventable cause of intellectual disability caused by abnormal formation of thyroid, thyroid hormone synthesis defect, and many more rare causes. Worldwide incidence is 1 in 2000 to 1 in 4000 live birth. But in India, ICMR task force conducted a study involving more than 1 lakh neonate, which showed the incidence of 1 in 1172 per live birth, which was much higher than worldwide data. Newborn screening should be done in all infants because prompt diagnosis and early treatment result in grossly normal neurocognition in adulthood. Development of thyroid, first endocrine to develop, originate from floor of primitive pharynx at the base of tongue through outpouching of endodermal epithelial cell at 3 to 4 weeks of gestation. It migrates to thyroid bed by 7 to 8 weeks of gestation. Thyroid follicle cells and colloid forms at 10 weeks of gestation. Congenital anomalies associated with development of thyroid gland is thyroid agenesis, lingual thyroid, aberrant thyroid, thyroglossal cyst, and fistula. Fetal thyroid physiology, maturation of thyroid gland completes by the end of first trimester. Thyroid follicle cell and colloid formation seen in 10th week of gestation. Synthesis and secretion of T3, T4, TSH starts by 12 weeks. HPT axis starts developing after 20 weeks of gestation, and stimulatory effect of TSH by T4 starts by the end of second trimester. Wolff-Chaikoff effects matures by 36 weeks of gestation. Maternal fetal hormone interaction. Placenta is permeable to maternal iodine and TRH but impermeable to TSH. T4 and T3 crosses the placenta in physiological relevant amount. That is, fetus remains in anabolic state, so requirement of thyroid hormone is very less. Hence, this phenomena is to prevent the fetal overexposure to maternal thyroid hormone. Placenta secretes deiodinase 3, which converts the T4 and T3 partially into reversed T3, which is an inactivated form, and partial amount of T4 and T3 crosses the placenta. T3, T4 that crosses placenta remains the sole source of thyroid hormone in early gestation. Children born to mother, a study has shown that children born to mother having low T4 concentration during pregnancy have low IQ than having normal T4 during the pregnancy. Immunoglobulins such as thyroid receptor blocking antibody or activating antibody can also cause placenta. Perinatal changes after delivery with cold exposure and clamping of cord. Abrupt TSH surge seen up to 60 to 80 milli-international unit per liter within 30 to 60 minutes of life, which declines to 20 milli-international unit by 24 hours of life and gradually normalized by first week of life. Simultaneously, T4 also rises parallel to TSH, peaks by 24 to 36 hours and gradually falls to 4 to 5 weeks after birth. Preterm also show same response but have blunted response. Congenital hypothyroidism causes. Permanent causes are thyroid dysgenesis, dyshormonogenesis, iodine deficiency, central hypothyroidism or TSH receptor resistance. Permanent transient causes are endemic iodine deficiency, iodine excess, TSH receptor binding antibodies, maternal antithyroid drugs, transient hypothyroxemia of prematurity, sick euthyroid syndrome or consumptive hypothyroidism. So thyroid dysgenesis, it's the most common cause of permanent CH. Worldwide incidence is 85 to 90% of all total CH cases, but India it includes 56%. It includes agenesis, ectopic and hypoplasia. Ectopic accounts for 2/3 cases of dysgenesis worldwide, but in India, agenesis is the commonest with 78% of incidence. It shows female preponderance with male to female ratio is 1:2. Mostly sporadic, 2% cases can be familial. Disorder of thyroid hormone synthesis. 10 to 15% cases of congenital hypothyroidism worldwide, but in India incidence is higher, that is 48%. They are mostly autosomal recessive and causes goitrous hypothyroidism. So first step is defect in iodine uptake into the follicular cell by NIS gene. Mutation is SLC5A5 mutation. Second is transportation of iodide from follicular cell into the colloid is seen by pendrin protein, which is which is coded by gene SLC26A4, and defect in iodine transport. Along with SNHL, it known as Pendard syndrome. Now, defect in TPO causes impaired oxidation and organification, and defect in generation of hydrogen peroxide, which is required for oxidation of iodide into iodine, gene responsible at DOX2 and DOX A2, which causes transient hypothyroidism. Next is TG gene mutation, which causes defect in synthesis of thyroglobulin. Central hypothyroidism incidence is 1 in 16,000 to 1 in 20,000 worldwide. Defect in production of TSH either due to hypothalamus or pituitary. Presence with other pituitary hormone deficiencies such as hypoglycemia and suspected in infants presenting with hypoglycemia and micropenis. Mutations are seen in several genes responsible for isolated TSH deficiency. Transient hypothyroidism, it contributes 15% of total CH cases, iodine deficiency being the commonest cause worldwide, but in iodine sufficient country, maternal antithyroid drugs and iodine exposure in neonate is the commonest. TSH receptor blocking antibody can cross placenta freely. Such patients have history of autoimmune thyroid disease in mother and sibling. Incidence is 1 in 1,80,000 newborns, subsides around 3 months of age, 3 to 6 months of age. Maternal antithyroid drug can cause transient CH, typically resolves in 1 week, does not require any treatment. Liver hemangioma produces type 3 deiodinase, which causes consumptive hypothyroidism. Transient hypothyroxemia of prematurity, commonly seen in preterm born before 31 weeks of gestation, causes our HPT axis immaturity along with acute illness and medication like dopamine and steroid. Dopamine and steroid causes decrease in TSH secretion. It shows low T4 and normal to low TSH. Treatment is controversial, but studies have seen that if given before 27 weeks of gestation, can be given. Sick euthyroid syndrome, inappropriately low TSH with low T3 and T4 due to suppression of HPT axis, medication, low TBG or decreased peripheral conversion of T4 to T3. When to suspect congenital hypothyroidism? If a newborn is presenting with lethargy, slow movement, hoarse cry, feeding problem, constipation, macroglossia, umbilical hernia, large fontanelle, hypotonia, dry skin, hypothermia or prolonged jaundice. Newborn screening, as per the IAP recommendation, universal screening either by cord blood or DBS by heel prick on day 3 to 5 postnatal, cord blood to be taken from placental end, TSH reported in serum unit, that is whole blood unit, to be multiplied by 2.2 to adjust the hematocrit. Newborn screening test strategies. Primary TSH and backup T4. That is TSH is measured first. If abnormal more than 20, then T4 is measured. It is most sensitive for diagnosing primary CH, but likely to miss central hypothyroidism and delayed TSH elevation. Recall rate is lowest, that is 0.08%. Primary T4 and backup TSH. In this, T4 is measured first. If low TSH is measured, it is sensitive to detect cases of central hypothyroidism and delayed TSH elevation as seen in preterm, low birth weight and sick newborns. Miss mild cases where TSH are elevated but T4 remains low to normal. Recall rate is 0.3%. Combined T4 TSH screening is ideal but has high recall rate and expensive. Methods of screening: cord blood. Advantages are it is painless, not affected by TSH surge, and patient can be early discharged. But disadvantages: other disorder cannot be screened. Dry blood spot by heel prick. Advantages is other disorder can be screened like galactosemia, phenylketonuria, G6PD, but trained personnel is required for sample collection. Can be done in baby who are home delivered. It is painful procedure and needs special assay and labs. Interpretation of NBS according to ISPE recommendation: TSH, that is cord blood or dry blood spot. If TSH is less than 20, it is considered normal and no further evaluation is required. If it is between 20 to 40 milli international unit per liter, repeat venous sample to be sent after 7 to 10 days of life. Between 40 to 80, a confirmatory sample is sent and treatment if abnormal values in repeat sample. If more than 80, then confirmatory venous sample is taken and treatment is started immediately. Do not wait for test result for starting the treatment. The interpretation of confirmatory venous sample according to ISPE guideline, which is taken after 72 hours of life. If TSH and T4 is normal, then no further testing is required. If TSH is high and T4 is normal, TSH high, that means more than 20 in 2 weeks of life and more than 10 after 2 weeks of life. Repeat TSH to be sent after 2 weeks. If TSH comes less than 10, it's considered normal, no treatment required. But if more than 10 persistent beyond 3 weeks of life, treatment should be started. If TSH is normal, but free T4 and T4 is low, that is free to T4 less than 1.1 and T4 less than 8 microgram per deciliter, treatment should be started. High TSH and low T4, treatment should be started. American Academy of Pediatrics 2023 guideline says if TSH is more than 40, treatment should be started immediately after taking confirmatory venous sample. If TSH is between 20 to 40 international unit, then confirmatory venous sample to be taken within 24 hours. In confirmatory venous sample, if TSH is more than 20, treatment should be started. If TSH and T4 is normal according to age specific limit, no treatment is required. If TSH is less than 20, then we'll see free T4 level. If free T4 level is low, treatment should be started. If free T4 level is normal, then patient should be kept on follow-up for 1 to 2 weeks more. If TSH is more than 10 after 4 weeks, treatment should be started. This is the same algorithm in elaborated form. Imaging etiology. Imaging for etiology. Attempt to perform imaging should never delay the treatment. USG of thyroid gland and technetium 99 scan are complementary to each other. Hence, if available, should be done simultaneously. Thyroid scan should be performed before starting the treatment or 2 to 3 days after starting the treatment. If imaging could not be performed at the time of diagnosis, it should be done after 3 years of age after stopping treatment for 4 weeks. This is an image showing technetium 99 scan, normal thyroid uptake seen in thyroid gland and salivary gland. This image shows no uptake in thyroid gland, no uptake in thyroid bed, hence thyroid agenesis, thyroid recepting antibody, NIS defect or TSA receptor resistance can be a possibility. This image shows uptake at the base of tongue, which is seen in ectopic thyroid. This image shows enlarged thyroid gland with increased uptake, which is seen in dyshormonogenesis. Now, approach to etiological diagnosis on the basis of USG thyroid and thyroid scan. If USG thyroid gland shows absent gland and thyroid scan show no visualization, means athyrosis. And if thyroid scan show ectopic visualization, ectopic thyroid gland. USG show enlarged gland and thyroid scan show increased uptake. There is possibility of dyshormonogenesis, endemic iodine deficiency. And if reduced uptake on thyroid scan, that means maternal anti-thyroid drugs. If USG thyroid shows normal size gland and scan shows reduced or no uptake, there is possibility of thyroid receptor blocking antibody, NIS gene mutation and TSH receptor resistance, which is seen in our case. Per deciliter and free T4 between 1.4 to 2.3 nanogram per deciliter. TSH kept at the level of 0.5 to 5 milli-international unit per liter after 3 months of age. Treatment initiated before 14 days of life has better outcome, and rapid normalization of TSH shows better development in later childhood. Duration of therapy, structural abnormality require lifelong treatment. Dyshormonogenesis, treatment should be in dyshormonogenesis, treatment should be stopped for 4 weeks at 3 years of age and reassessment of thyroid hormone to be done. Aim is to normalize the T4 in 2 weeks, normalize TSH in 4 weeks, avoid hyperthyroidism and promote normal growth and development. Follow-up and monitoring. 0 to 6 months, 1 to 2 weeks after starting the treatment, followed by every 2 weeks till the TSH is normalized, then every 2 months till 6 months of age. After 6 months to 3 years of age, every 3 months. Beyond 3 years of age, every 3 to 6 months. 4 to 6 weeks after change in doses. Regular growth monitoring, development assessment and hearing and cardiac assessment to be done. Indication of repeat TSH screening. It should be repeated after 2 to 4 weeks of life. In preterm born before 32 weeks, should be done at 36-week corrected gestation or 4 weeks of life, whichever is earlier. VLBW infant, sick newborn admitted in an ICU. If blood transfusion and exchange transfusion done before taking NBS sample, monozygotic twins and Down syndrome. Evaluation for permanence. If thyroid dysgenesis and TSH increases above 10 milli international unit per liter after first year of life, permanent congenital hypothyroidism and treatment is required for lifelong. If no such finding, then stop treatment for 4 weeks after 3 years. Measure TSH and free T4. If free T4 level is low and TSH is more than 10, then permanent CH treatment should be given for lifelong. If free T4 and TSH is normal according to age specific range, then transient CH considered and treatment should be stopped. So learning points are, it's the commonest preventable cause of mental retardation, hence all newborn must be screened for CH. T4 and free T4 values must be looked along with TSH. Repeat testing to be done in preterm, low birth weight and sick newborn. High doses of levothyroxine shows better outcome and rapid normalization of TSH shows better development. Thank you.
Any cases, Dr. Ravinder, to moderate, and any questions from the audience?
Just why 5.9 kg, I think. Just one message, ke please, I mean, you know, it seems to be very common problem, but you know how it has been missed. Even we started treatment at 2.5 months, sorry, and what we have given to the society, still he's having delayed milestones. It could be prevented by just one test. And you look, I mean, scenario of our society, it is thanks to Maulana Azad Medical College, thanks to Seema Kapoor ma'am. She started the new project, and now each and every baby of my hospital is being screened and diagnosed for CH and CH. Otherwise, in my hospital, there is approximately 6,000 deliveries per year. Incidence, what she told is, thanks to Kapil and 1 to close to 1 to 1200 babies, and this is for permanent. Yeah. and this is for permanent, sir. If you include the transient one, the incidence is somewhere close to 1 in 750 kids. So you know, yearly I have missed, because I have not screened in 6,000, I have missed close to 5 or 6 hypothyroid babies. So what we have given to the society after having so many of logistics and infrastructures. And fortunately, we are fortunate enough that we are in Delhi and we are now doing it. If you look at the scenario of periphery, even at Delhi, private hospitals, many private nursing homes, they are not doing. So my humble suggestion, humble request, please start doing just this one newborn screening, else we'll continue to give society at least so many thousands and thousands of retarded neonates, which is obviously not benefit for the society. Thank you. If any queries there, although Dr. Ankita and Dr. Kapil, they have given the literature and theory. So dose is somewhere 10 to 15 microgram per kg body weight. However, if you have a severe hypothyroidism, which is our case, better to close to 15. So probably we have given somewhere 13 to 15. And now, you know, all over the world, internationally, the guidelines are revising. If you look at the SPA guideline, they say if the screening TSH value is more than 80, you start the treatment, don't wait for the report. But look at the just January 2023, American Academy of Pediatrics says if it is more than 40 TSH, start the treatment, don't wait for the report. However, do the confirmatory venous sample, see the report, then take the decision accordingly. Because sometimes, maybe very rarely, this is falsely elevated or increased. Otherwise, obviously, you have to start the treatment. So this is just a very simple message. Even in my institute, someone has seen this baby at the age of 1.5 months, but he missed. He couldn't, you know, advise the thyroid hormone, because usually we are not advising it. Yes, because mother was very spinal. Thanks to mother. Yeah, you know, on further asking the history, mother says कि sir मैंने पिछले महीने भी बोला था मेरा बच्चा नहीं है अच्छा, but you know in the busy OPD and वो सब कुछ देखा उसने, all the units reflexes are normal. He said okay. Thank you. Maybe, ma'am. Absolutely correct. Absolutely correct. Absolutely correct. Very true, ma'am. Hats off to that mother.
Nice presentation. Thanks, all of you and team member of IMA Delhi. Thanks. I am Dr. R.P. Soni, practicing in East Delhi.
So, sir, from now you said all samples of newborns you attend.
Yeah, please. Hey, sir, as you are the practicing pediatrician, can you tell me, I mean, you are attending the delivery, are you sending the sample or are you all the colleagues they are sample and screening all these units or not?
मेरे पास जो यूनिट्स आते हैं अगर करवा कर आते हैं तो कोई बात नहीं, नहीं करवाते हैं तो मैं उनको एडवाइस करता हूँ. लेकिन बहुत सारे पेरेंट्स हैं जो रूरल बैकग्राउंड से आते हैं तो वो इस चीज़ को इग्नोर कर जाते हैं, कहते हैं डॉक्टर साहब तो ऐसे ही करवाते रहते हैं. ये भी एक लिमिटेशंस है, ठीक है. लेकिन मैं कहता हूँ, सभी से कहता हूँ कि आप करवाइए. और मुझे याद है एक बच्चा मेरे 20 साल पहले आया था. मेरे मोहम्मदन फैमिली थी, यहाँ अपनी जाफराबाद में रहते हैं. तो मैंने उनको बोला, डायग्नोस किया, मैंने कहा ये कंजेनिटल हाइपोथायराइडिज्म में इसका लाइफ लॉन्ग ट्रीटमेंट चलेगा. उसने स्टार्ट किया, उसके मदर ने. कुछ दिन के बाद उसके फादर ने बोला कि नहीं बेकार की बातें करते हैं डॉक्टर साहब. वो फॉलोअप में आती रहती, उसके और कई बच्चे थे. उसका एक बच्चा जब 12 या 16 साल का हो गया, मेरे पास फिर वही बच्चा आया. वो दैट वाज मेंटली रिटार्डेड. मैंने उससे बोला, हमने कहा आपसे मैंने बार बार कहा, वो जब भी आती थी मैं उससे बोलता था कि नहीं आप करवा ट्रीटमेंट स्टार्ट रखिएगा, ज़िंदगी भर देना है. नहीं मानी. अब कहती है कि हाँ आपकी बात नहीं मानी. हमने कहा अब तो टाइम निकल गया.
Yeah, I would love to have some words from Faridi sir. Faridi sir, you have been to Delhi, now you are at Lucknow. So, I mean, what is the situation at UP? Because still, you know, incidence is so high. So, is the newborn screening are being done, and what is your?
I am in UP. I am still considered a Delhiite. So, but yes, right. But as a policy, it is not there. In medical colleges, yes. Like in KGMU and PGI and our place, we do advise for screening. In fact, we have got two path kind, and it's a nice, the two firms with which we have got, they have given a very reduced rate. But as a routine, just like we are giving vitamin D to every newborn, it's not being done in every newborn. I think that's a good message, simple, a good message that screening must be done. I agree with you.
Thank you. Sir, just one humble request to our IAP President, Dr. Anurag Agarwal. Please, from the front of the IAP, please advise this to Government of Delhi that each and every newborn of this Delhi should be screened for hypothyroidism.
Thank you so much.
एक बात और सारे पीजीज के लिए, जितने भी पोस्ट ग्रेजुएट यहाँ पे स्टूडेंट्स हैं, आप सबको स्क्रीनिंग तो करा रहे हैं मेडिकल कॉलेज में, यहाँ भी करा रहे हैं. पर व्हाट इज मोर इम्पॉर्टेंट इज स्क्रीनिंग के लिए सैंपल भेजने के बाद उसकी रिपोर्ट कलेक्ट भी करनी है. यू हैव टू एंश्योर दैट रिपोर्ट इज अवेलेबल और उसको इंटरप्रेट करना है. जस्ट सेंडिंग अ सैंपल बिकॉज रिपोर्ट अगले दिन नहीं आती. द पेशेंट इज डिस्चार्ज ऑन द नेक्स्ट डे. रिपोर्ट कम्स आफ्टर 4 दिन. उसके बाद से देन रिलेटिंग दैट रिपोर्ट टू द पेशेंट विच यू हैव सेंड बैक is also very important. तो वो भी चीज़ ध्यान.
आप लकी हो 4 दिन में आ जाती है.
Thank you, a nice presentation. I just wanted to know one thing, like this child, the cardinal feature of neonatal hypothyroidism is prolonged jaundice, which is present. इसमें नहीं था, क्यों? नहीं. But
it was there. But it was not.
अच्छा.
It was there. Baby developed jaundice on 6th day of life. Our phototherapy was not required. So this is.
So with this, I would like to felicitate our young presenter, Dr. Dr. Kapil, please come forward. I request Madam Indra Taneja to please come and honor the young student. And to honor Dr. Ankita. Yeah, Dr. Ankita. Ma'am, please honor Dr. Ankita also. I request Madam to honor Dr. Piyush Jain, HOD Hindurao Hospital. आ जाओ बच्चों. And a token of appreciation to Dr. Ram Prakash Soni. Please, sir. Please. Sir, Madam. भाई रविंदर के लिए भी बचा एक मोमेंट हो. हाँ है. पीयूष जैन एक्साइटेड हो रहा था. घर मुझे जाना है साथ में रविंदर के. क्या बात कर रहे हो?
I think this should go to Madam Taneja because she has asked so many questions. She was so interactive. I feel so happy. So, ma'am, this is for you. This is for you. This is for you. Oh, sure.
I would like to say a few words to my young students here, PGs and medical students. I am Dr. Indra Taneja. I did 50 years back from Lady Harding. I graduated, and because my husband, who is Delhi IITian, went to USA in '68 on scholarship. So when he came and then we got married, so right away after Lady Harding MBBS, I had to go to USA. I did my MD pediatrics there. And I taught in the medical school over there for 40 years in the University of Medicine Dentistry. And then, because both of us, my husband, IATN, who had never worked in India because right away went there to do master's PhD, and I went straight. Even my internship I did in USA, Indian internship, and got the degree from there. Sorry, I'm talking too much about myself, but I just wanted to tell you that, and now for the last 8.5 years, but both of us decided, because as Swami Vivekananda said, don't serve your aunt at the cost of your mother, because we were serving aunt, America. So now we have both come here for last 8.5 years, and I am also trustee of the NGO Buds. Dr. Rajiv said most of people know because he's, Dr. Rajiv said, I am trustee of his NGO Plus. My husband and I started our NGO, Next Step in Health, Education and Environment. Health and education being my field, and education and environment, my husband's field is doctorate engineer. So we are trying to, what I do is, for last 8.5 years, retired, took the retirement from USA. There's no retirement in USA. I'm sorry, I'm talking too much. But what we are doing, I'm doing, going to Haryana and UP villages and giving lectures to the students in the schools, group of 200, 300, 100, and going to schools and giving them the education on health, nutrition, hygiene, menstrual hygiene, how to promote health and prevent disease. And also we adopt the schools where we can do things for them from our NGO, Next Step in Health Education. I'll give the card to Dr. Agarwal. That skill development, once they graduate, what is their now future for them? So if they need some skill development course like Tech Mahindra or Apollo Med or something, we help them, also help the schools for buildings like solar panels or rooms or labs like physics lab or biology lab, etc. So this is what I just wanted to, and when I heard about this one, I wanted to attend this because the topic was very close to my heart.
डॉक्टर शालू गुप्ता सर को मोमेंटो हमने नहीं दिया. सर प्लीज आइए ना. डॉक्टर रविंदर देंगे डॉक्टर शालू को. I think with this we come to the end of the program, and I hand over the mic to Dr. Anju ma'am for vote of thanks. Thank you, ma'am.
I think I should thank everyone who's staying till the end of the program and listened to us and cooperated with us. And it was a very enlightening session with so many stalwarts attending the session, and the cases were at the different end. At one time we are missing hypothyroidism. At one end we needed a genetic diagnosis for HLH. So everything is important. As postgraduates, we have to learn approach to the patients and add on to the knowledge. Thank you, Dr. Anurag, for the opportunity.